Thank you for joining me for this topic of nursing care of the newborn. The chapters that I used were ATI chapters 23 through 26. These are initial newborn nursing assessment. Typically in that first 2 hours, along at the same time the mom is recovering, the baby is recovering. Baby's been through a lot. So they'll do 30-minute vital signs, including a temperature every time. No blood pressure in the newborn. I'm hoping in the clinical site you have had a chance to get your hands on a newborn and do a heart rate, but you'll typically listen for a full minute, an apical rate, and you'll put your stethoscope on the point of maximum impulse, PMI. It's mid-clavicular at the fourth intercostal space. That's important. You should know how to use a bulb syringe to clear airways and nasal passages. And you should know how to do an axillary temperature. Do a quick visual survey. You want to wear gloves when you're handling newborns. They just came through the birth canal or through an abdominal incision, and they have mom's blood and body fluids all over their skin. So for infection control and for safety, please wear gloves. Their umbilical cord should be clamped. They should have appropriate muscle tone. Look at their fontanelles, the soft spots on their head, and the sutures where the bones meet. Look for any gross malformations, and then look for any transitioning difficulties. And that just means, are they having trouble breathing? Are they having trouble with perfusing their body? So that's the initial nursing assessment of the newborn. So our priorities as nurses are to keep the baby safe, prevent complications, and we do that by performing physical assessments. One of the first things that you have to understand is that the immediate response of the newborn after birth is to adapt their cardiovascular system. And on the next slide, you'll see fetal versus extrauterine life circulation. So this is a change from placental to pulmonary gas exchange. Before delivery, the mom was doing all of that gas exchange through the placenta. Afterwards, the newborn does that through the lungs. You can note the normal heart rate on this slide, and there's also changes in blood volume. Understand that the placenta holds a portion of the newborn's blood, and therefore some of that blood volume can change after delivery. So this is that slide that shows the 3 shunts in fetal circulation, and you can see those blue arrows pointing to those 3 structures. On the bottom, the ductus venosus, it shunts oxygenated blood around the liver from the mom through the umbilical vein. So the umbilical vein comes in from the placenta, and then the ductus venosus shunts that oxygenated blood around the liver, so that it goes right into the inferior vena cava and into the right atrium. In the right atrium, there's a structure that communicates to the left atrium, so that more oxygenated blood travels into the circulation faster. The baby doesn't need to oxygenate its blood in the lungs because it's not breathing yet. So some of that blood is shunted through the foramen ovale into the left atrium. The other shunt is from the right ventricle. The blood would be pumped into the pulmonary arteries, and there's a communication between the pulmonary arteries into the aorta. That's called the ductus venosus. Immediately after birth, when the baby starts breathing, there's a shift in the pressure in the lungs that allow that foramen ovale to close, and that's usually an immediate response. The ductus venosus may take a few days to close. So this is just a list of how that circulation changes after birth. And it's good to know, but I will not be testing on the minutia on this slide. This is a graphic on the stimulation for respiratory effort. The big one is that cold air that touches the baby's skin. The baby was in that really warm environment, and then it comes out, it's wet, it's about 20 or 30 degrees cooler in the environment, they're wet, and it's shocking. So that's the stimulation that the babies draw that air into their lungs. There are also some internal stimuli. This is for your knowledge. I will not be testing on the minutia on this slide. So this is a comparison slide, how the fetal systems change once the baby is delivered. So let's take a moment to talk about the role of surfactant. Surfactant is a substance that's manufactured in the fetal lungs, and more surfactant is manufactured the longer the baby's inside. What surfactant does is it lowers the surface tension of liquids. So think about the baby inside the mom's uterus in the amniotic fluid. All those alveoli are filled with amniotic fluid. But when the baby comes out, it needs to fill the alveoli with air. And without surfactant, the surface tension of that fluid is pretty high, and it takes a lot of effort to open those airways. What surfactant does is it lowers the surface tension of that liquid so that the baby can take an easier first breath to fill all those lung passages and alveoli with air. And because surfactant is manufactured by the fetus later in pregnancy, this is the reason that many preterm newborns have respiratory distress syndrome. Also on this slide is the normal respiratory rate for a newborn, and you will be taking vital signs on your newborn in the clinical site. You should be aware of the normal breaths per minute for a newborn and report anything out of range. Also be aware of nasal flaring. If a baby's nostrils or nares are flaring with every breath, that's a sign of some respiratory distress. Also, retractions are like that sucking in of the skin of the chest. So it could be subcostal or underneath the ribs, below the ribs. It could be intercostal, which is between the ribs. And it can be suprasternal, which is right above the sternum or breastbone. More likely you'll see those subcostal retractions, as they're the most mild type of retractions, and respiratory distress, the severity increases as those retractions ascend into the sternal notch. The other thing that you want to be aware of is that babies may grunt, and this is like they make a noise with every expiration. So this means that they're actually trying to hold their alveoli open by increasing that interthoracic pressure. So nasal flaring, retractions, and grunting, they're not normal for the newborn, and we'd want to report that. Please note that newborn respirations are usually irregular and shallow. They shouldn't be labored, and babies may have short periods of apnea. It's called periodic breathing. So a baby might breathe a couple of times very rapidly and then stop breathing for up to 10 seconds and then start breathing again. This is not abnormal, it's just a finding. It's unique in newborns. And of course, looking for symmetrical chest movements. Along with symmetrical chest movements, you'd want to auscultate the lung fields, and immediately after delivery you may hear some scratchy sounds, crackles, but that amniotic fluid is usually absorbed fairly quickly. So anytime you would do an assessment and you're hearing crackles in the lungs, you would want to report that. This slide just shows you the normal vital signs of the newborn. So this is very important. You should know these things for the exam and also on the clinical site, because if you assess your newborn and you find vital signs that are out of range, you need to report those out of range vital signs to the baby's primary nurse. This is also an important slide to know that the normal weight, the average newborn measurements for the newborn are between 2,500 and 4,000 grams. And the length is between 45.7 and 53.3 centimeters. We do record things in the metric system. Also to note on this slide is that babies are weighed every day, every 24 hours at about the same time every day. And there's usually a policy on what time of day they weigh every newborn on the department. They track this. It is normal for newborns to lose some weight over the course of the first several days. And there's a lot of reasons for it. Those babies are usually overhydrated, and that's a normal thing. When they're inside the uterus before they're born, they have a lot more hydration than they will have after a few days. The other reason is because of nutrition. So if you think of breastfeeding mothers, their milk hasn't come in until the third or fourth day, and we'll get into that into the next lecture. However, the babies are only getting just a few milliliters of colostrum or nutrition over the first couple of days of life until the mother's milk comes in. Now, formula-fed babies, they generally don't lose as much weight or any weight. We do have to monitor all babies though. And as we are monitoring babies' weight loss, we want to be very mindful of babies that lose 10% or more of their body weight, and that's reportable to the pediatrician. That is not normal. These are the initial newborn assessments. I want you to pay attention to the abbreviations of AGA, SGA, and LGA. On your clinical paperwork, you probably already saw the graphs on the newborn paperwork. And if your baby, when you plot out the weight, the length, the head circumference, when you plot those things out on those graphs, if your dot falls above that line, it's above the 90th percentile, that baby is large for gestational age, or LGA. You might hear those terms on the clinical unit. If your dot falls below the lowest line, then your baby is SGA, small for gestational age. They're lower than the 10th percentile. We would also want to measure head, chest, and abdominal circumferences. Not all units measure abdominal circumference. And then kind of falling out of favor is that gestational age assessment. I include it because it's in your book, but it is a subjective assessment of the physical maturity and neuromuscular maturity, and you may or may not see that performed where you are at clinical. For the head to toe assessment, I like to observe my newborn before I disturb them. How do they appear? Are they quietly alert? Are they resting quietly with their eyes closed? Are they crying? What color is their skin? What color is their mucous membranes? Look for range of motion if they're moving around. If a parent or someone is holding them, then you can assess some bonding between that adult and the newborn. We can also look at proportions and symmetry. The head should be proportionately larger than the body. That's a normal finding. We want to look at posture. We talked earlier in a previous presentation about fetal positioning. Term babies usually have a flexed posture. You can also assess for skin color. And I have a few terms noted on the slide here on that left-hand side. The one that you're probably not familiar with is the term plethora. And plethora just means a lot of something. So if a baby has plethora, you might hear the baby looks plethoric. That just means they're very red and ruddy looking. They have a lot of extra red blood cells. And we'll talk more about why babies have extra red blood cells in a coming lecture when we talk about some newborn complications. Some common skin findings are milia, which look like little whitehead pimples. They generally tend to appear on the nose, the chin, and the forehead. They're just immature oil glands, and we would want to teach parents that they shouldn't pop those. The next one, I'm not going to attempt to say. They are stork bites, and I have pictures on a coming slide. They're just a little raised capillary beds, and these usually fade within the first year or two. Generally, they appear on the forehead, the eyelids, the back of the neck. The next one is erythema toxicum, which is the newborn rash, and sometimes you'll hear it referred to as a flea bite rash. The baby doesn't have fleas, but this rash looks like flea bites. It's a fairly common finding. Some babies don't have it, and others are just polluted with these little raised papules surrounded by some reddened tissue. Hemangiomas are, again, a different type of capillary beds. Vernix is a waxy white substance that the skin produces in the uterus before the baby's born. It kind of acts like cold cream to keep the baby from getting all pruny and wrinkly while it's in the amniotic fluid. And that vernix kind of wears off as the pregnancy progresses. So term or post-term newborns may only have a little bit of vernix in the creases, like their groin creases or their axilla. Whereas preterm babies, they're going to be coated, their backs are going to be just coated with vernix that you could scrape off, and it's very thick. Also, you may see little tiny flecks of vernix in amniotic fluid when a mom has ruptured membranes. That's a fairly common finding. The next term is lanugo, and that's fine downy hair that the baby grows. A lot of it's on its back, and it's usually shed before delivery, but some babies can have more lanugo on their backs even at term. And there are more terms and common skin findings you can see listed in your ATI book. You can also find some traumatic skin findings, and that would include bruises, just bruising from the delivery, forceps marks, which are tiny bruises on the face. A vacuum extractor mark usually happens on the occiput of the baby's head. It's a big sucker bite, and it can result in some trauma to the skin of the baby's head, and the skin can become quite macerated. There could be a fetal scalp electrode laceration with that internal lead, little scrapes, and also lacerations. And you'd want to check your babies that have had a C-section to make sure that the surgeon didn't inadvertently lacerate the baby when they did the C-section. I have seen that happen. Sometimes as bad as the baby needs like a little butterfly stitch to close that laceration. This is a picture of those skin variations. That left-hand picture on the top is the stork bites. You can see a strawberry mark, the nevus vasculosus on the top in the middle, port wine stain. The middle picture are Mongolian spots. They are usually found in darker complected ethnicities like Mediterranean, Middle Eastern, African American, those darker complected ethnicities. Right next to that, right next to those Mongolian spots on the right-hand side is a picture of that erythema toxicum, that flea bite rash or newborn rash. So it's just that little white papule surrounded by a little bit of inflammation. Underneath, on the lowest part there, you'll see babies that have half pink and half pale. That's Harlequin sign. It is unusual, however, it's a very benign finding. That little brownish spot on the baby's abdomen is called a café au lait spot, and it could indicate neurofibromatosis. And then you'll also see some hemangiomas on the baby's cheek. So once you do that initial survey, you'd want to start your head to toe assessment, assessing the fontanelle, both the anterior, which is right on the top of the baby's head, and you want to find the posterior fontanelle. I usually run my finger back the sagittal suture, which is that middle suture line. The babies don't have fused skull bones. So I run my finger back that sagittal suture to try to find where it meets the occipital bone, and that's where I find the posterior fontanelle. The posterior fontanelle usually closes fairly rapidly within the first few months. The anterior fontanelle usually closes by 18 months. At birth, they should both be soft and flat. If they're bulging, it may indicate increased intracranial pressure. If they're sunken, then that could indicate dehydration. The suture lines, when you evaluate them, you would use terms like open if you can note a space between those skull bones. Overriding is when they're one on top of the other, and it's usually not a whole lot, but you would want to note that. That comes from the way the baby's head has to fit through the mom's birth canal, and those skull bones can kind of override one another in order to fit best. That overriding sutures usually go away within the first 24 to 48 hours. And that last word, approximated, just means that they meet up real nice. They don't override and they're not gaping open. Other common findings are caput succedaneum, which is just a diffuse swelling on the baby's head. This comes from just the trauma of the head coming down through the birth canal. The head acts as kind of like a little bit of a battering ram, and it may have some trauma, may have some swelling. So we call that caput. The next one is called a cephalohematoma. It is a traumatic finding, and the cephalohematoma is a collection of blood underneath the periosteum of one of the skull bones. So that swelling won't cross suture lines, and that's the difference between caput and the cephalohematoma. Caput is diffuse, it crosses suture lines, whereas the cephalohematoma will not cross the suture lines. You'll also hear the term molding, and in lay terms, this is the baby when they have a cone head. And that happens because the baby's head has to fit through the mom's birth canal, so that it takes on the shape in order to fit. Molding usually goes away within the first 24 to 48 hours, and the baby's head rounds out real nice. Next, we'd look at the eyes. We want to make sure they're normally placed on the face. They should be symmetrical and have a normal shape. There should be eyeballs in the orbits, and there shouldn't be any epicanthal folds except in Asian ethnicities. Some babies have a little bit of edema, but there shouldn't be any discharge. The exception there is sometimes the ointment, the eye ointment that we use, the erythromycin, may cause a little bit of irritation, and we might see some discharge. Scleral hemorrhages, the iris color is usually gray or blue, and truly I don't do a pupillary response. It's really hard to get babies' eyes open, and I do not assess this when I do my assessment. For ears, we want to look for normal placement and symmetry. The top of the ear pinna should align with the outer canthus of the eyes. Lower set ears could indicate some kind of an anomaly and some kind of a renal anomaly as well. We want to make sure that the ear canals are patent, that there are no skin tags or ear pits pre-auricular in front of the ear, little tiny pits or sinuses. They shouldn't have any discharge there. And usually a hearing screen, it's regulated by state law. We usually do hearing screens after 12 hours of life before they're discharged. So that's a state law that nurses that work in labor and delivery and newborn should be aware of. Babies are obligate nose breathers, so their nares need to be open in order for them to breathe. So they have that flattened appearance, and that actually helps them when they're feeding to be that nose breather. There shouldn't be any discharge. We shouldn't see flaring. You might notice some stuffiness, and that's pretty common finding. It comes from the estrogen that the baby's exposed to, the mother's estrogen that the baby's exposed to when they're inside the uterus. We want to assess for choanal atresia, which is an abnormal membrane that prevents air from moving from the nares down into the oropharynx. So we would close the baby's mouth and occlude one nare and listen for air movement, and then we would close or occlude the other nare to make sure that there's no choanal atresia. Sneezing is completely normal. That's how babies blow their nose, and they're just trying to keep their nasal passages open. Looking at the mouth, again, we want to look for symmetry. We try to elicit the rooting reflex by stroking the baby's cheek. The baby should turn toward the cheek that is stroked. We want to look for pink and moist mucous membranes. There shouldn't be any teeth, but you may find some Epstein's pearls, which are like milia inside the mouth. We want to assess the tongue to make sure there's no tongue tie. That's a frenulum that extends to the tip of the tongue, prevents tongue movement, and it may result in speech impediments later in life, and it also could cause some feeding difficulties for those breastfeeding babies. We want to assess to make sure the hard and the soft palate are intact, and we do that by sliding our finger back into the baby's mouth so that we don't feel any defects. As we're sliding our finger back, we can assess the sucking reflex, and as we slide that finger back further, we should be eliciting the gag reflex. That is a protective mechanism for the babies that protect their airway. When looking down at the neck, it should be freely movable with normal range of motion. There should be no webbing. And remember that newborns need to have their head supported all the time. Their neck muscles aren't strong enough to support their head. So when you're handling newborns, you have to make sure that you support that neck. Palpate the clavicles to make sure they're intact. Even with an uncomplicated delivery, sometimes a fractured clavicle can happen, so you'd palpate along the clavicle to feel for any lumps, bumps, or crepitus, which is like a Rice Krispie type feeling. The arms should have normal range of motion. If there's a fractured clavicle, one of the telltale signs is that the newborn won't have normal range of motion of the affected side. For the chest, we want to look at the respiratory rate and the heart rate. There shouldn't be any adventitious breath or heart sounds. It should be symmetrical. That's a recurring theme. We should be looking for symmetry. No retractions, and breast buds are normal in that term newborn. They should be anywhere between like 3 and 5 millimeters upon palpation. Looking down the torso into the abdomen, it should be soft and rounded. You should be able to hear bowel sounds on both sides of the abdomen. Looking at the umbilical stump, for the first several hours, the umbilical stump is very moist. You may be able to identify the one umbilical vein and 2 arteries, but after the cord's dried, you really won't be able to identify those. You would assess for any bleeding, discharge, or herniation of that umbilical stump. To teach cord care to the parents, you'd want to make sure that you teach to clean around the base of the stump at least every day with soap and water and drying thoroughly. I like to use Q-tips to do that and to teach parents. There's a lot of exudate that forms at the base of that stump. It's kind of like when you have a brush burn and around the scab it gets gooey. So we want to clean that exudate away. But make sure that you teach to keep that area dry. They have to dry that area very well. And then fold the diaper, the top of the diaper, down away from the umbilical stump so that it promotes good air movement and drying. You'll want to palpate for femoral pulses and assess for any inguinal masses. That wouldn't be normal. Looking at the genitalia of the male, you'd want to make sure that both testicles are descended into the scrotum. Look at the tip of the penis to see whether the urinary meatus is located at the tip, or if it's on top of the penis, that would be an abnormal opening, that would be epispadias. Underneath on the dorsal side would be hypospadias, and those babies shouldn't be circumcised. You will also look for scrotal rugae. With a circumcision, you'll assess for bleeding, discharge, and any signs and symptoms of infection. Right after a circumcision, there are usually a few drops of blood in the diaper, but after the first couple of, like the first hour or so, there really shouldn't be any more bleeding that you'd note in the diaper. To teach circumcision care to the parents, you would want to make sure that they know to put Vaseline or petroleum jelly in the diaper to prevent that area from sticking to the diaper. Also, when stool would get onto that circumcision area, they can take a really wet, soppy washcloth and squeeze the water out over top of the penis to wash that stool away. And that's how you would teach the parents to take care of that circumcision area. We don't want to teach them to wipe at it because that's a really sensitive area. It's very sore, and we want to promote healing. For females, you may notice swelling and redness of the labia. That's a pretty common finding with a term newborn female. The redness and the swelling comes from the exposure of estrogen from the mom. Also, there may be some mucousy discharge, and maybe around like the 3rd or 4th day of life, I teach parents of baby girls, they may have like a little bit of streaks of blood in that mucousy discharge. And that's called pseudomenstruation. It's very, very common, but I like to teach it because if I didn't know about it, that would really alarm me. We also we'll spread the labia to see if there's any vaginal skin tag. In the diaper area, we should expect about 6 to 10 voids every day once the mother's milk comes in, or if it's a formula-fed infant. And we expect that first void to be within 24 hours of birth. Also, we want to assess for anal patency, and we'd expect a stool within 24 hours of birth. If there's delayed voiding and stooling, we should report that to the physician. Looking at the extremities, they should be in a normal position with normal range of motion and normal muscle tone. Babies do have purposeful movements, usually hand to mouth. Everything should be symmetry with equal lengths. We want to assess for congenital hip dislocation, so we'd want to do some normal hip rotation. We do check to make sure there are 5 fingers and 5 toes on each of the extremities. There shouldn't be any extra digits, no webbing between the digits. We'll look for palmar and plantar creases on the palms. If they have one crease across the middle of their palm, that would be called a simian crease, and it can be associated with those individuals with Down syndrome, but it's not an absolute finding. There are perfectly normal karyotype individuals that have a simian crease. And we'd also want to note acrocyanosis. We talked about this in a previous presentation. Acrocyanosis means that the whole body is pink, but the hands and the feet are blue. And that's just some immature circulation. The baby might be a little bit cold, and that acrocyanosis usually only lasts a few days. Looking at the back, we'd flip the baby over and we would look at the back. We want to run our fingers down to make sure that the vertebral column is intact, and spread those little buttocks cheeks apart to look for a pilonidal dimple and any hair tufts. If you can't see the bottom of a dimple and the baby has hair tufts, both of those are abnormal findings that you would report to the pediatrician. This slide is the reflexes that stay, and you know that you all continue to have pupillary, blink, and so forth reflexes. The ones on the right-hand side are the reflexes that don't stay, and you, in your clinical experience, your instructors should be teaching you about these reflexes. For your paperwork, you'll want to note when that reflex extinguishes, and that's found in your ATI book. Sensory perceptions, babies can have all their senses intact, they're just not mature. So that their sight, they prefer sharp contrasts like black and white. They prefer the human face, and they can focus best at 8 to 12 inches. And funny enough, that's about the distance from the baby's eyes to the mother's face when she's cradling the baby in her arms, or any other individual. They recognize familiar voices because they hear those voices while they're still inside the uterus. They love cuddling and snuggling and that tactile stimulation. They recognize odors, and they do recognize their mother's smell. They are actually looking for and recognizing the smell of the mother's colostrum, which is similar to amniotic fluid. They prefer sweet tastes, and they can perceive pain. I'm not sure which newborn pain scale is used at UPMC, but I believe the NIPS, the Neonatal Infant Pain Scale, is used at Conemaugh. Socialization is when the babies start to interact with their environment, and truly right after birth they begin to react with their environment. The cry is their communication, but it shouldn't be high-pitched. That would be abnormal. Babies cry to communicate their needs to people. We can't observe or assess for orientation, but we can observe for level of consciousness and an appropriate interaction with the environment. And babies should have some self-quieting abilities. Usually it's that hand to mouth or thumb sucking that you'll notice most. This slide is important because, and I hope you get to see it on the clinical units. Typically, after a delivery, think about, the baby's been through a whole lot. Their adrenaline is really elevated. And they're going to be really alert for at least the first 30 minutes to 2 hours after birth. This is a really nice time for the parents and the baby to start bonding, and it's also a good time to begin feeding, especially for breastfeeding. After that first period of reactivity, the babies go to sleep. They're tired. So that period of decreased responsiveness lasts for up to 2 hours. And for love nor money, these babies are not going to wake up. Then after that decreased period of responsiveness, they go into the second period of reactivity. And again, the newborn wakes up, is very interested in reacting with its environment, interacting with its environment. And again, another really good time to bond with the newborn as well as feedings. Now, you will be doing some med sheets on vitamin K, the eye prophylaxis, which is erythromycin ointment, and the hepatitis B vaccine. Babies are administered vitamin K because they don't produce it yet. Vitamin K is produced by gut flora, and they just came out of a sterile environment. So vitamin K aids in coagulation, and this is especially important for our little boys that are undergoing circumcision, but it's good for all of the babies to help prevent intracranial hemorrhage as a result of some birth trauma. The erythromycin ointment that I hope you get to see or actually perform on a newborn is placed in their eyes to help prevent blindness due to sexually transmitted infections. So if a mother has a sexually transmitted infection and we haven't identified it, as the baby descends through the birth canal, the baby can pick up that sexually transmitted infection in their eyes. It would lead to infection of their eyes and potentially blindness. So it's a really safe and easy way to prevent newborn blindness. The last one is the hepatitis B vaccine, and I know that every one of you has had that series of 3 shots to help prevent hepatitis B. It's recommended that that first shot be given right after birth to decrease the risk of hepatitis B infection in the future. Now, I did post out on your Canvas site under this week's module a hyperlink that's a really quick and easy read about why your baby needs these 3 medications, and I encourage you to read it. It's not required. I don't need proof that you read it, but I think it will add to your understanding of the need for all 3 of these medications. This slide is important for you to know, so I would highlight it. It's important for you to know that the H&H is elevated, and that's normal in a newborn. Platelets are about the same as they are for the adult. Red blood cells are more than what an adult has, and take another peek at the white blood cells. It is very common for babies to have elevated white blood cell counts, and it doesn't mean they have an infection. So just take a note of those lab values. They are important. Let's talk a little bit about thermoregulation of the newborn. Thermoregulation just means it's a balance between heat loss and heat production. And you can see that there are a few things at play here, but babies haven't had to do any thermoregulation before they're born because the mother did that for them. So babies conserve heat through vasoconstriction. That's part of the reason they have acrocyanosis, but you may also see pallor or mottling of the skin. Heat production is primarily through non-shivering thermogenesis, and I know that's on your preclinical worksheet. Non-shivering thermogenesis is a good thing to know because babies can't shiver, so they have to produce heat a different way. They burn brown fat in order to produce heat, and brown fat is only found in newborns. And as the baby spends time in the uterus maturing, more and more brown fat is put down. So if you think about this, you can think about preterm babies. They don't have as much subcutaneous fat or brown fat. And then babies that have intrauterine growth restriction also do not have as much fat or brown fat. So, and we'll be talking about intrauterine growth restriction in the coming weeks, but those smaller babies, they have less fat. Fat serves as an insulator too, so they'll lose more heat because of the lack of insulation, and they won't have as much brown fat to burn to help produce heat. We want to promote safety, and we want to be especially aware of airway obstruction. On your skills checklist for clinical, you'll see the use of the bulb syringe. We always want to use the bulb syringe on the mouth because it's a larger volume, and then suction the nose. If the baby has an airway obstruction, you might see some evidence of respiratory distress like flaring, grunting, and retractions, and it may lead to low oxygen saturation. We want to monitor babies for hypothermia, and you can see the interventions that we'd employ to help get the babies back up to a normal body temperature. The best way, and the one way that's been around since the dawn of mankind, is skin-to-skin contact. You would take a baby with only their diaper on and lay it belly to chest with the mom, making sure that the head is turned to the side so that their nares aren't occluded by the mother's chest tissue. Then we would add layers, a hat, maybe a warm blanket, or 2 warm blankets. We can also use a radiant warmer, those warmers that you've probably seen in the delivery room that throw down heat that warm the baby. We can also put a baby in an isolette. You might have heard it called an incubator, but it has a very nice constant heat, and the baby won't lose heat and will warm up in that isolette. Whenever you do any interventions, whether it's on a newborn or an adult, after you perform an intervention, you'll always want to go back and do an evaluation. So once you do skin to skin with the mommy and the baby, you'd want to reassess that temperature in about a half an hour. So make sure that you go back and assess or evaluate your intervention, and then document your evaluation. These are the 4 types of heat exchange. Conduction is when it's direct transfer from a surface to another surface. So that's why we pre-warm that radiant warmer before a delivery, because if we have a baby who needs resuscitation, we don't want baby to lose extra heat on an unwarmed radiant warmer, that cold surface. Convection is through air currents. So if you look at an radiant warmer, you'll notice that there are sides on all 4 sides, and that's for safety, but also to prevent those air currents from convecting the heat off of the baby. Evaporation, one of the first things you'll see done when a baby is born is drying the baby off, because a lot of heat is lost when there's evaporation. So we want to promote good thermoregulation. We want to make sure that we keep our baby dry. And then radiation is heat lost through the environment. So again, we want to not position babies in their bassinets near an exterior wall, especially near in the winter time, so that their body heat isn't radiated out into the environment. These are some challenges of thermoregulation. They're unable to shiver, they have thin skin. We talked about not a whole lot of fat, so not a lot of insulation. They can't regulate their body heat. They don't change posture, they can't adjust their clothing or their blankets, and they can't tell us if they're too hot or too cold. Cold stress is ineffective thermoregulation. And we don't want our babies to have cold stress. That's why we assess their temperature about every 4 hours while they're in the hospital. Ineffective thermoregulation can lead to respiratory distress, which then leads to hypoxia, acidosis, and it can also lead to hypoglycemia because that brown fat is being used up, and the babies don't have any more stores in order to produce heat. So you might see pale skin, we talked about this, mottling, cyanosis, and tachypnea, retractions, grunting, and nasal flaring. The next thing we'll talk about is screenings for newborns. One of the things that we'll do when we talk about the complications in the newborns, some newborns are at high risk for hypoglycemia. So those babies will screen for hypoglycemia by doing heel sticks at ordered intervals. We also want to make sure that their bilirubin doesn't go too high. Bilirubin is that substance that can build up in the skin that causes jaundice. So we want to monitor that, and I believe in both clinical sites they use a transcutaneous bilimeter that flashes the skin, and then the nurses plot that out on a chart. When it gets too high, there are usually standing orders to order a serum bilirubin, and again, that's plotted out based on how many hours old the baby is, and of course we'd notify the provider when bilirubin is out of range, when it's too high. Another screening is a state-regulated screening called metabolic screening, and it screens for things like phenylketonuria, which is a metabolic disorder, congenital hypothyroidism, galactosemia, another metabolic disorder, and sickle cell disease, and a whole boatload of other different metabolic disorders. What you can teach the parents is that the nurses collect a few drops of blood from the baby's heel and put it on filter paper. And after it's dry, they send it to the state lab for analysis. Chances are, since all of these metabolic diseases are rare, chances are the parents will never hear anything about it. But if the state lab discovers something, the parent will be notified, and the child will have to be taken in for repeat screening. So if there's a problem, many of these diseases can be regulated with diet or medications, and the sooner we recognize that a child has one of these disorders, the sooner the treatment can proceed and the less permanent damage that will be done. We monitor baby's hearing. That's also a state-regulated requirement. We test baby's hearing anywhere after the 12 hours of life. The metabolic screening has to be done after 24 hours of life. The last one is the critical congenital heart disease screening. And we're looking to make sure the baby doesn't have like a coarctation of the aorta, which you'll learn about in pediatrics in just a few short weeks, or any other cardiac anomalies. And the nurses will place a O2 saturation probe on the baby's right hand and on one of the feet, and then they see if there are any differences between those two readings or whether they're too low. If they are too low, the pediatrician is notified, and they order an echocardiogram to see if there are any congenital heart defects. These are just some pictures about circumcision. I know a few of you have probably seen a circumcision by now, and we talked about circumcision on an earlier slide. Discharge teaching, of course, we would want to teach the signs of illness. Babies that have vomiting for more than a regurgitation, we would definitely need to let the doctor know. Fever over 100.4. Dehydration, so we would teach about fontanelles being sunken, lethargy, disinterest in feeding, all of those intractable, inconsolable crying, those things the parent would want to notify the pediatrician. We want to promote safe sleep. Babies should be placed on their back to sleep, nothing in the crib, not even bumper pads, no blankets. They should be placed in blanket sleepers. We need to teach car seat safety, that the back seat, in the middle of the back seat facing the rear of the vehicle, is the safest place for children up to 2 years of age. After that, they can be spun around forward facing, but they should be in a car seat up until they're 12 or 80 pounds. Don't quote me on that. I won't be testing on those details, but that's something that we should be teaching, is car seat safety. We need to provide anticipatory guidance on the newborn screenings, which we just discussed, follow-up care with immunizations, and basically what I tell parents is that if they keep all their newborn well baby checkups, that their baby will have all the immunizations that they'll need to enter kindergarten when they turn 5 years old. We would do a bath after the temperature is stable, and I hope that's something you all get to do on the clinical unit. We would do a sponge bath only for the first 5 to 7 days until that cord and circumcision area are healed. Some hospitals allow and promote tub baths even before the cord falls off. We did talk about cord care earlier. We want to teach how to diaper, and of course I mentioned about folding the top of the diaper down away from the umbilical cord until it falls off. And then for clothing, I teach the parents that they should dress their baby in the same amount of layers that they have on, plus one more layer. Then if they notice their baby's hands or feet are cold with that extra layer, they can put another layer on, or if the baby seems a little bit sweaty, they can remove a layer. We talked about safe sleep, but we also want to make sure that the babies have tummy time. So they should be on their abdomen, but only when awake and only when they're supervised. And that helps decrease the risk of that malform, that flat spot on the back of the baby's skull. Feeding may start right after birth. Usually within about 45 minutes, women who are breastfeeding, they've already started, the baby's already latched on. We want to tell them, both breast and formula feeding moms, that they should feed on demand. Breastfed babies usually about every 2 to 3 hours, and formula fed babies usually about every 3 to 4 hours. We would want to teach a proper positioning and how to burp. Burp between breasts for breastfeeding moms, and burp with every ½ ounce, and that helps decrease the regurgitation, and it removes the air from the baby's belly. They don't need to give any other fluids other than formula or breast milk. They don't need juice, they don't need extra water. Their nutrition is enough fluid requirements for them. So this is just a comparison slide on the differences between breast and formula feeding. Breastfeeding, human beings, like other mammals, make the milk that their babies need. And we know through research that breast milk is better than formula. However, we want to make sure that babies are fed. Fed is best. we need to support the mom who's breastfeeding and assist her. There is a latch tool that assesses how that baby is able to grasp the breast and how much support and information and assistance the mom needs. We should be teaching about how to store and express milk, and then address concerns like sore nipples, engorgement, and mastitis. And we'll talk about mastitis when we talk about postpartum. For formula feeding families, we'd want to talk to them about the different types of formula, whether it's ready to feed, concentrate, or powder. We need to teach safe formula preparation, and that has to do with boiling the liquid if they need to dilute either the concentrate or mix it with the powder. We also want to make sure that they know that they have to accurately measure the amount of formula with the amount of water. We don't want them to dilute and give their baby a more dilute concentration. That can lead to electrolyte imbalances, and some babies have died because of it. So they really should not try to make that can of formula last any longer than it should. And they should be exclusively breast or formula fed for at least 6 months. Talked a little bit about this with elimination. With breastfed babies, some breastfed babies stool with every feeding, and so 8 to 10 times a day. Other breastfed babies might only stool once every several days. It just depends. But for voiding, we can expect, once the mom's milk is in, about 6 to 10 voids every day. The stools are different between breast and formula fed babies. Meconium is that first stool. It's very dark and tarry and sticky. It really doesn't have much of an odor. It then transitions into that mature stool. And on this slide, you'll see that transition of the different stools. We need to prevent infection, and we need to teach the parents how to protect their infant from infection. So good hand washing, making sure that they keep their baby away from individuals who are sick, and then prepare them for follow-up care. Usually, the pediatrician wants to see a breastfeeding newborn within a day or two of discharge for a weight check and jaundice check. But that formula-fed baby is usually at about 2 weeks, and that's for a weight check. These are signs and symptoms indicating there's a problem, and we talked about that top one already. That's signs and symptoms of respiratory distress. Apnea is also a problem, as you might know. Generalized cyanosis, a flaccid body posture with no muscle tone, that's not normal for babies. Tachycardia or bradycardia, elevated or a decreased temperature. These are all things that we would want to make sure that we teach parents before they go home.